A long week. Hi, everyone. Welcome back to the afternoon session of the House Healthcare Committee. We have with us today the Agency of Human Services, Amy Samuelson, who's the Secretary, Rich Donahue, the Chief Financial Officer, and Shayla Livingston, the Policy Director. So welcome. You've been in here, so I'm not going to do introductions. The committee, the reason I asked the Agency of Human Services to come in today is there is a piece in our budget. So this is in the DEVA book, for those who followed that. And it's a $10 million. Yep, it's on that too. $10 million for, and I forget the exact language, but basically it's to help providers who are still needing assistance to be stabilized since the pandemic started. And we had allocated money previously, and there's being more asked from AHS. So I thought it would be great to come in and hear about where what happened with the money before, how it's been used, and why there's still a need going forward. With that, I'm going to turn it over to you.
Good afternoon, everyone. It's good to see you. I'm Jenny Samuelson, for the record, Secretary of the Agency of Human Services. And I'm going to start this today with the context of why we need the money and some of the work that's happening around it.
That's right.
It's that time that we're already throwing things. Okay, I think I'm.
Beware.
So during the pandemic, the Agency of Human Services, as part of the response, provided and addressed many of the capacity issues in the healthcare system, but through federal funds and through state funds to really prop that system up as we were going through the pandemic. What folks may or may not be aware of, and I know that you've had many people come through the committees and describe this, but coming out of the pandemic, the healthcare providers are almost experiencing more strain now than during the pandemic. They are seeing the impacts of system closures and not reopening, including in our mental health system and our long-term care system, where they're experiencing increases in demand. So significant pressures up. And what you might have heard from some of the providers as a couple of the key measures is that in our hospital system, particularly, you've got a significant number of individuals who've been waiting or were waiting and starting to clear up for a bed in the mental health system and or in our long-term care system. They're ready for discharge from the hospital, but there isn't a placement upstream or downstream. And it's really a symptom of the system's capacity being down on both ends of that. It's not good for Vermonters, and it's not good for those healthcare systems. So as we were coming out of the pandemic and seeing that strain, the question that intersected with the conversation about healthcare reform. And so we were charged to convene the healthcare reform work group. And I'm going to ground us there because it links back to the funding. That work group, as it came together and we listened to healthcare providers, and it includes providers and payers and the Green Mountain Care Board and the agency, really, as we came forward, had two main charges. One was to look at short-term stability. We knew that we could not address what was going to happen in our long-term healthcare system without addressing the pressures that we have in front of us today. The systems are not going to be able to move forward, as well as looking at our more traditional long-term sustainability, which has been a question in our healthcare reform for a while. So over the summer, we worked with the provider groups, and the agency primarily alone worked with them because we wanted to really be able to dig into their business and their work. And they came up with and identified workforce, regulatory pressures, system flow issues, and revenue issues as their primary pressures that they were experiencing in the system. And that gave us a grounding not only for the stability issues that we had been looking at clearly, which were closures and other things, but what could we do to address the workflow in our system? And again, this became a forum that will be an ongoing forum to work with and and address our healthcare reform. And so in the summer, we focused on that stability. And in the fall, we began to establish a framework for the longer term work, as well as began to look at what we would do with our hospitals for their long-term sustainability. As we looked at the utilization of these funds that we were doing, we began to identify this past year that we had about $25 million of GF that was appropriated to the Agency of Human Services. We have expended at this point about $21 million of that, with $4.9 million still remaining, but more requests right now to deal with both the trying to reopen the system or keep the system open and trying to deal with the flow issues that we uncovered this summer. For the funds this past year, we have, in order to open capacity in our skilled nursing facilities, recognized while we were doing the rate studies and other things that you'll see reflected in the budget this year to address their inflationary pressures due to staffing and workforce costs, for those facilities who had closed beds, which are quite a number of them, we allocated about 20% of what we've expended so far to helping to open up closed skilled nursing facility beds. In addition to that, we had supplemental payments to our hospitals. I don't know if folks are aware, but coming into the Green Mountain Care Board process this year, the majority of our hospitals were significantly in the red. We provide every year payments to the hospitals called disproportionate share hospital payments, also known as DISH payments. They're a way to help compensate the hospitals who have a high percentage of Medicaid. They gave us an avenue, as we were seeing these exorbitant pressures on the hospitals, an avenue to provide additional funds to those hospitals in a one-time payment. We were able to match it up against Medicaid funds, and that helped to stabilize our hospital system, which was at risk and jeopardy in a manner that's a one-time trend.
I'm just trying to follow the slides and they're different, so I don't know if you're.
Sorry, that's my fault.
Oh, okay. I just thought I was a little.
You're not confused.
Thank you.
All right. I should give more of a nod to Shayla. Next
I
slide.
love not being cuckoo. Just
Maybe.
You'll send it to us?
Yes. It's right.
Yep.
Thank you.
Yep. Then you saw me pause too. I was like, my papers are out of order in terms of what's on the screen behind me. So we also provided for our hospitals for our providers who were in our system. We saw closures of our skilled nursing facilities. We saw our private non-medical institutions for children and youth. We saw home health agencies. We saw many of those programs submitting requests for funding in order to keep their doors open. And for those who were not skilled nursing facilities or those private non-medical institutions, we did not have a funds flow to stabilize them. And so we used these stability funds in order to keep their doors open. Lastly, there were expenditures for hospitals that were not federally fundable during the pandemic, and for other healthcare systems like our skilled nursing facilities where we provided funding and support, and so a portion of them were used there. Shayla, are we on the provider stability fund?
You're good. Yeah.
Okay, so overall, coming out of that, those were some of the things that we used to stabilize the system. Again, our systems are still really brittle, and coming into the preparation of this year's governor's recommended budget, we knew that we already had more than $16.5 million of requests for one-time funds to address the infrastructure issues, for example, in hospitals to provide better and more appropriate flow for mental health patients. We know that there are a couple of our of institutions who are going to submit for financial relief payments because of imminent closure issues. So we knew that we had that in addition to the work that we'd been doing, that we were going to need to continue to stabilize the systems while things that you saw in the budget that were part of the stability plan, like opening up a long-term care facility that can serve individuals with mental health, while we were doing Well, we're getting our alternatives to emergency departments also in the budget. While those things were coming to fruition, we knew that we were going to need to continue to relieve pressure on the system as a whole. And thus we implemented about $10 million. We asked for in the governor's recommended budget, $10 million to continue to address those issues. Without it, we are concerned that we will begin to see some of the facilities that are upstream and downstream of the hospitals close, or we can't address the fundamental issues that came out in the stability work that would work on some of those workflow issues. So I'm going to pause there and see in the rest of the deck, just so folks know, I won't go through it, but I've included a copy of the stability recommendations that you can see that came out this summer. And those are really coupled with this stability work that I just was talking about. They really say, here are some of the things that we need to do in order to stabilize our system. You will see many of those in the AHS's budget. And then here are the one-time funds that are coupled with that. And so we probably won't go through them today, although we could. But it gives you a sense of not just the emergency funds that we're talking about with these $10 million, but what we're doing more broadly in terms of the stability work under the healthcare reform work group. And that will be ongoing, and again, includes the payers, the Green Mountain Care Board, and the providers to come up with those solutions.
I do, just sort of a fundamental question. We had 44% of the stabilization fund going to hospitals for the supplemental payments to compensate for low Medicaid rates. Why don't we just raise the Medicaid rates so you don't need to stabilize the hospitals?
So I would characterize it differently. So the dish payments this year and what we were actually seeing when we talk with the hospitals is that they're seeing pressures related to an exorbitant increase in travelers coming into their system. I can speak from the psychiatric hospital that we operate. Normally we would have single or low double digits percentage of travelers. We had over 50% at one point of the individuals in our system who were travelers. We worked with the Brattleboro Retreat. They saw the same thing. As we begin to stabilize the system, those travelers went from $75 an hour prior to the pandemic to, in the middle of the pandemic, as much as $300 per hour. We are beginning to see that come down on an ongoing basis. And so for this funding for this year, the request from the hospitals really was, we don't believe that this will be an ongoing pressure, but instead a one-time workforce pressure, and hence the dish payments.
Thank you.
Yeah.
What's the process for someone applying, and what is the criteria for determining who gets the money?
So I'm going to answer, and then Rich actually does a lot of the reviews of the application. So again, there are a couple of different pieces here, and I can give we can give examples of each. For some of our providers, they're applying because they're imminently going to close. For them, they submit a request. In that request, they present their financial information and data, cash on hand, what they are in arrears in terms of their funding going out the door, whether they're able to make payroll. They present a case and a request for the amount of money that would stabilize them and a plan for what stability looks like long-term. Again, many of these are one-time pressures or pressures that we're dealing with in rate reviews. So I wonder, Rich, if you have anything to add to that, at least on the emergency relief.
Nothing substantive. I agree with everything that the secretary just cited as an overview of our process. There is an internal application that's vetted by the Secretary's office and me and my team. And as Secretary Samuelson just testified to, the intention here is to provide one-time bridge funding type payments to allow a provider to get to the other side of what is a current challenge.
And then the second area of funds, and I don't want to wash this out too much, is that we have identified areas in the system. So for example, closed long-term care beds. And in those areas, either providers have approached us with solutions, or we have approached the provider community through the forums that I've discussed, where we have an opportunity to say, what are some solutions to the current problem? And I mean, those are, it's when the hospitals have no beds left in order to, in their ICU or in their med surg floor, we've said, okay, what is that we can do in long-term care? And we've had at least currently 3 of our nursing home facilities said, if you can cover the differential in travel or costs while we continue to recruit for permanent employees, we can open up beds that are closed. And so we've reviewed those proposals against the data and the pressure that we have, and we've allocated funding towards that.
So, which is extremely important. And just to remind everyone, if someone is staying in a bed in a hospital and they no longer need the level of care of the hospital, but they have nowhere to be discharged to because there's no nursing home bed or there's no mental health bed in another facility, the hospital is not getting paid to staff that bed. So it is a flow and a cost issue for hospitals, which is extremely important. And at the same time, we've spent the last day and a half listening to various healthcare providers coming in and saying, we can't survive on the Medicaid rates that we have. I have an email from one OBGYN who will no longer take Medicaid patients for certain gynecological surgeries. We heard from Health First this morning, who over the past year or so, several primary care providers have closed in their network. EMS, which is a fundamental piece of our, continuum of care, just came in and they are really struggling. So I think you're facing a committee right now that is wondering where they get their stabilization funding from.
So there's a couple of answers there. Transportation providers, we have provided stabilization funds from. Again, we're looking at short-term and long-term. These stability funds are short-term. What you saw in the governor's recommended budget following the work with the healthcare stabilization discussions this summer was with limited resources that are available, prioritization of ongoing rate increases. So you saw dental rate increases, you saw it in choices for care, you see it for our hospitals. We're looking at, is there another way that we can provide support to hospitals this year, potentially by drawing down federal funds? That's not in, there's a placeholder, but that's not in the budget. So we looked across the systems, and where we could, based on the priorities that were set forth by our provider communities, we allocated funding for rate increases or other stabilization activities in order to keep us moving forward. For those who are looking for imminent stabilization funds, they can reach out to the Agency of Human Services, and we're working to use this funding to stabilize them, particularly for one-time cost issues like the workforce issues that we're facing right now.
Okay, so it's a prioritization based on information that you all have reviewed as to how you're allocating the funding.
Reviewed with, where the pressures were in the system. This summer when we talked with our healthcare providers, they really prioritized primary care, and particularly mental health investments in primary care. They prioritized mental health and substance use. So you see that reflected in enhanced services for alternatives to emergency departments and mobile crisis, which go into services in many of those organizations that are looking. They're saying, we're providing this anyway, let's provide this better and in a way that will help stabilize us as organizations. It was in long-term care, and so we looked, and identified for many of them, the pressure are more acute, complex patients as well as inflationary costs. So in long-term care, you saw inflationary increases. You also saw increases in home health rates for choices for care. We used the best information we had and the priorities, and then hospitals were looking, as I said, at a federal option, best information that we had at the time that we had it to prioritize where we gave rate increases and where we saw significant enough instability in the system that providers were in imminent danger.
Art?
Yes, could you by chance go back to the slide that showed the 10 million and the 16 million? I just want to make sure I'm clear on what that is.
Yeah. So in the governor's recommended budget,
Yes,
there's 10, so on the slide that's before this,
Yeah.
it shows what we did with the $25 million that we had previously. So far, at this point in the year, we've expended 21 million
correct,
with 4.9 remaining.
yeah,
So if you go to the next slide, the
okay,
governor's recommended budget for this year that refreshes, and it's called the COVID Contingency Fund. It's also called the Healthcare Provider Stability Fund. We've asked for that. It's not a normal budget line item for the agency. It's something that was put in during the pandemic to help
but
stabilize
it's
these
already
organizations.
in the budget, correct?
It's in the governor's recommended
All right,
budget.
okay, all right,
And the reason that we did that is that we have, at this point in time, we have about $16.5 million of one-time proposals that are in flight for consideration for funding.
so you're going to fund 10 million of that? 16?
We'll end up funding, we've got 4.9 or almost 50.
Oh, okay,
it's
yep,
almost
yep,
15.
yep, I'm sorry.
Yeah,
Yep,
almost
left over.
15 million. And some of those.
I didn't know if you were going to spend from that till
Yeah.
June.
We will, and some of those will get potential
Okay.
projects started. Others, I think,
Okay,
those are the original proposals that folks submitted. Some of them may be scaled down once they've taken a chance to look at it. Others, they may drop, but this gives us enough money to both consider those requests for extraordinary financial relief and do some of the one-time infrastructure projects that hospitals and other types of healthcare providers have asked for.
now, what do the providers and hospitals have to show you to qualify for that money?
So to qualify for that money, it goes, for extraordinary financial relief, they show us detailed financial documentation of where they might be in arrears on their
Do they have to
accounts
be in
receivable.
arrears?
They have to be in imminent financial jeopardy.
Okay, yeah, all right.
Yeah, so
Understood.
an example is, we have an agency right now whose accounts receivable and accounts payable, they don't have the money to pay for
Yeah.
it. They're struggling to meet payroll, and they provide a critical service in the community that would affect the overall stability in the system. Then we have our financial department, who is used to and is in depth going through that. They look at it, they review it. The organization also submits this is what we're going to do to stabilize plan. And that's what we do. We review critically.
And you require that as part of it, that this is what you're going,
Yes.
this is what we plan to do to
Yes.
stabilize, okay.
Again, there's two components.
Yeah.
Another component can be us identifying a pressure. So for example, hospitals, some of that 16 million,
Yeah.
are hospitals who have identified, for example, one of them in their emergency department from a flow issues and standpoint is they're having a hard time stabilizing individuals with mental health concerns because they don't have a physical room. All they have are screens between them. It's loud. It's not. So for them, it's one-time funds to do that. They believe in doing that, they can stabilize an individual more quickly, and such help them get to the community. And so that would be another proposal. That came at a request of the agency saying, we see an issue in mental health flow in the hospitals. How can we improve that flow? And some of those proposals you saw us build into the budget, like alternatives to emergency departments. We knew that we couldn't fund with this. So
Yeah, thank
is
you.
that? Yeah,
thank
thanks for
you.
the question.
So before we move on, I just want to it's kind of related, but just, we've been having, as I said, we've had people come in over the last couple of days who did not have something in the budget, and so it's an additional budget ask. And through the process, not necessarily at the table, but I think some offline conversations have been that the way we all seem to operate here in the legislature and within the agencies is that, we're really siloed, right? So we hear from DMH, we hear from DEVA, we hear from AHS, we hear from BDH. And everyone has a piece of the budget. Some is Health Human Services, some is here. And what we can't get our head around is what is the continuum of care strategy for healthcare in Vermont? And so we see bits and pieces here and there. And, we're talking in our committee, like, I've always felt like we need a big map and we layer everything upon everything and figure out where everything is and then where are we lacking? I mean, we know there's a hole in the Northeast Kingdom, but where else are there things? And I'm just curious what, from your perspective as the Secretary of the Agency of Human Services, how you see the continuum of care vision or how it plays out in the decisions you all make. And is there a vision, for the whole
system? Thank you for that question. First, I want to start by saying also the providers, it's really hard decisions. I know that you're going to have to make. And so I just want to say thank you to you all for, we hear the same things. It's not easy. And I recognize that as you go into your budget proposal. And so there's a couple of different directions I can go with that question. First, I'm going to harken back to what we said about the budget.
Right.
And this year we did our budget differently, and we put all the departments in the room and we asked them to consider the continuum of care because they intersect significantly as they came up with the budget decisions. And so the way that you receive testimony here makes it difficult to see that a little bit. But I want to emphasize that did happen and will continue to happen at the agency so that we're not operating as siloed as we have in the past. And I think the pandemic really gave us that. I think the second part is that, I mentioned before that coming out of the pandemic, we are in a different place when it comes to our continuum of care than we were before the pandemic. We knew that we had parts that were brittle before we went into the pandemic, and those parts are even more strained now. But what the pandemic did for us is that it really put shined a stiff light on those areas and the intersect between them. And so we, as an agency, we see the continuum of care across both healthcare and human services. In fact, in many cases, I don't separate the two out. What I can say right now is that given what we see in front of us, we have convened the providers and the others to really begin to look at that system of care. What they identified was no different than what the agency identified in order to address the system of care issues right now, where they would prioritize looking is primary care, mental health and substance use. The next term I always get I get yelled at no matter what I say. So long-term care, or skilled care, you'll hear folks talk about that. And in our hospital systems, that doesn't mean we're not looking at our other systems. And so what we are doing right now with our healthcare providers through the healthcare reform work group is looking at what is it that we need in those systems, not just today, not where the puck is, not the emergent situation that we have at our feet, but longer term. And so I don't have the full vision for you today, but I have the way that we're trying to get towards a vision, at least in something that's digestible, while the agency also works on other problems external to that. The Healthcare Reform Advisory Committee is looking at short-term stability and long-term stability, but we know that in order to what we heard for feedback from our providers is that the focus on payment and what we do with our negotiations with Medicare and Medicaid and the commercial insurers feels academic and in the weeds to them. And we also heard that right now, given what they have in front of them, that they don't have the time to pick their heads up and say, what is it that we need to do to transform the healthcare system? And so in response to that, building on the work that we've been doing with the work group, which we thought could come up with those transformative ideas, we are going to convene a group of experts, past experts from Vermont and experts nationally, to help give us those ideas. We'll take the information that we get from Act 167 is going to look quantitative and qualitatively. We will reflect on that through that group, and that group can then go back and advise the Green Mountain Care Board, the Agency of Human Services, and the providers through the work group, so that we can do this in partnership, no longer just provider-led, but public-private partnership. And that's where I think we're going to get the transformative ideas of not just do what we're doing now to stabilize the system, but where we need to go. And so I can't tell you what's the vision, but I can tell you where it is. I also can tell you that in each of those areas, in primary care, we know the pressures are access, mental health and substance use, panel management for chronic conditions, and complex care for our most vulnerable Vermonters. What you see us doing this year, because we know those are the pressures, because we already have a lot of inroads in work through the ACO and through the blueprint, is you see us making investments in one of those. When it comes to hospitals, we're moving forward with the work on 167 this year. So really doing an assessment at what we need at the local, regional, and statewide level. We also know that for long-term care, we have not done a full assessment on what the demographic trends are and what we need into the future in home health and in skilled nursing facilities. So we've commenced that work as a or are beginning to commence that work as a reflection in it. And then as we think about mental health and substance use, we had the 2030 plan. We've reflected back on that based on where we are after the pandemic. And you saw the Agency of Human Services, the advisement of the providers, again, public-private partnership, looking at what are the core services that we provide in the communities. How do we make sure all communities have those core services? And then all the way up through the hospital level of care, what is it that you need? And you see investments throughout the entire budget in those. And so that's the way of answering. You say, people often say it's complex, so we're just not going to understand it. I think what you're hearing is it's more like an onion. It's not complex, it's multi-layered, and we can't do one thing at a time. And so through AHS, who has a broad mission to look at that full continuum of care, what you hear is a commitment to work with providers to help identify not just what we're doing now, but that vision for the future through those work groups. And so I know it's a little long-winded to explain, but that at least helps lay out the process. It also, I think, demonstrates that we're not waiting until we have the perfect vision, but instead beginning to pick off things one by one so that we're making continuous progress, because this is something that's not going to happen overnight, but will happen over time. At the same time, we've negotiated the 1115 waiver. We are working with Medicare on that, so we can try to do a multi-payer approach to this across that continuum and working with our federal partners. But also now bringing in, we saw with Blue Cross Blue Shield and OneCare having a little stress over what was going to happen in healthcare reform, now bringing in our commercial insurers. So not only are we now flipping it from just saying how we're going to pay, which is what we've done in the past, to what is it that we need, and then how are we going to work with our payers to pay differently to support those needs. And so that's the process that we're undergoing, because the health system is a broad system and a broad vision.
And I appreciate that. And I mean, the work is amazing. And I think because you all are right in it and you have all the key players that we're on the outside, right? And we don't see the work that's being done. So I would maybe challenge us as you move forward, and especially next year for the budget season, the way you have changed the way you're doing the budget at AHS, it would be great to reflect that in the proposals that are given. And maybe we find a way that it's not each one just coming in separately, but we do realize how everyone is connected and how the continuum of care is working.
And how we made those decisions. The way I would reflect it back is, it's like you're trying to put together a puzzle and you don't have the box. And that's, I think one of the things that we as an agency have identified is there's so much that's happening in some of this stability work that we need to do a better job at being able to break it down and convey it on an ongoing basis. So I'd love help from the group here to think through how would it be best to receive that information so that you do have the box and not just the puzzle pieces, because you're getting bombarded. And that's what I was appreciating you for before. You're getting bombarded by the puzzle pieces and it's really hard.
Right. We don't know how it's all.
And I can appreciate sitting where I sit and having all of the departments. I really appreciate that.
I appreciate that. So sorry for dominating the conversation. Go ahead, Topper.
I'm just wondering, this group that you had working, I'm sure that other states probably have similar problems, similar to what we have. And I'm just wondering what kind of cooperation or collaboration people in your position nationwide are getting together to talk about the problems that they've got. And also, each one of those states talking to their congressional delegations so that we can get the federal government on board before our healthcare system collapses.
I think that's an excellent.
Each individual state probably can do better than the other, but we're talking about solving a problem just from this guy.
Yeah.
I don't think it can be solved state by state.
Yeah, we're 600,000 lives, like trying to influence some of our partners in the national trend. So it's a great question, and there's always more we can do. The secretaries for the Agency of Human Services across the country get together. The Medicaid directors also get together so that they have a lens into the healthcare space. We are involved in work with Millbank. We've been a little less involved since the pandemic. Millbank is a fund that pulls together folks, as does the National Association for State Health Policy Leaders, pulls together folks from different states to actually talk and dialogue about these problems. For me, that's essential. In addition to that, what we recognize coming out of the 1115 waiver, and I don't mean to dumb it down for everybody, but the 1115 waiver is our agreement with the federal government and how we run our Medicaid program. As we came out of that, we used a consultant who looks at all the national programs to help us formulate what we were doing there. We brought some of that learning into our negotiations with Medicare for our all-payer model agreement. Our all-payer model agreement is simply the way Medicare engages with the state. And it's not, it often gets thrown out as something more than that, but it's simply that. And when we felt like what was going to be proposed for the next model didn't meet Vermont's needs, we asked for support from NASHP, the National Association of State Health Policy Leaders, to help convene a group of states to talk about what we thought the next model should look like and what flexibilities we would need state to state, and then communicated that back directly to CMMI and through our federal delegations. So we could do a lot more, but the good thing is that we do have collaboration. It's also why we want to get that work group going, not just with experts from Vermont, but with experts who are looking at these specific problems in other states, because you would be surprised. There are some states that do some pretty cool things that are not the states that I would look to. It's not the Oregons and the Washingtons, but on a specific issue, it might be in Oklahoma or Oklahoma on social determinants of health screening, Louisiana on housing. So really having those experts who are consultants who can find those experts and bring them in has also been an exceptionally powerful tool.
Yeah.
We have to steal ideas shamelessly from other places so that it actually works.
I think that's all good.
Yeah.
We've been doing this for
A long time.
a long time, and we've got a whole bunch of information And what I would like to see, this is only personal, I would like to see something take place on the national level. Because I don't think there's any other place that we can do it unless they do it with us. And if I were in your shoes, that would be my goal.
We speak regularly to our delegation and to both Medicaid and Medicare, which controls a lot of the policy in this area.
Daisy and then Leslie.
Just a quick question. I really appreciate Lori's clarifying question just in terms of what the long-term vision is rather than these.
Like one-off, yeah.
Thank you. But isn't this the reforming Vermont's system of care? Isn't that referring to the waiver, the 1115 and our Medicaid plan?
Yeah, so absolutely.
So then doesn't part of that have to articulate the vision?
So our Medicaid waiver, which is the 1115 waiver, and our Medicare waiver, which is our what we get, or our Medicare agreement that we get, both of them have to be in sync at articulating the same vision and the same goals together. And that's been our goal, is to work with the 1115 team to say, these are the types of investments that we're going to make here in Vermont, and try to get Medicare and Medicaid to sync up so that we're able to do it from a population level and not just do it. Because if you go to your provider, I don't think your doctor asks, or your mental health provider, or anyone, who is your insurer, except for at the front desk when you check in the payment. And so you are right. They do state what our goals are, but they state them for Medicaid and they state them for Medicare, and they have to come together. Does that make sense?
And so where the flexibility lies is where we implement things like in our outcome measures and how those get implemented at the provider level.
Yeah, so I think we were recently talking with one of our payers who was having some angst. And I think where that comes together across payers is, what is it that we're agreeing that we want to change? How do we measure that we've been successful at that? And then how do we then evaluate the outcome? So what investments do we make? So financially, how do we measure the outcomes on the front end and back end of those investments? And then how do we evaluate that we're actually making progress towards our goals are critical in both the 1115 waiver and in the all payer model agreement. And it's interesting when you look at the all payer model agreement, not to go on a tangent, which I tend to. If you look at our all payer model agreement before, it does set out some goals, and it set out similar goals, prior to the pandemic, of the areas that we needed to work on. And we've made some traction in them, but we need additional traction, like mental health. So these are things you see across the country. They're not just in Vermont: mental health and substance use, long-term supports and services, home and community-based services, and primary care. And so and hospitals. So you really see them trending forward. First saying we're going to start with our hospitals and primary care, and then we're going to trend into we're going to create a plan for mental health and how it's going to come into the next plan. We're going to create a plan for long-term care. We got the pandemic shot us off it was at that moment when we were supposed to be working on those plans that the pandemic hit, and then things just got worse. But now we tangibly can see what the interplay is, and I think it's more clear than it ever has been before what we can do about it. Does that answer your question, Representative Echo?
No, no, I'm not going to say that about myself. Not about dumb questions, but
Yeah, she looks at me.
when you get, because you
They're all
always
really
say that.
smart questions.
When you get issued, like CMS sends out these Medicaid director letters, right? And they say, we have this new authority we're going to offer through Medicaid. You can now bill for this service or whatever, and so that you can better work with your schools or whatever. Why would we, if we have federal authority to do something that gives us a higher reimbursement rate, why would we not take advantage of every single one of those?
For that's so I would need an example of ones where we're not, but here's a couple of things. One, we need all of the Medicaid program letters that come out give us our match rate. It's never 100%. It can be, anywhere from 55% to 85%. Typically, if it's at that higher match rate, that higher match rate is for a short period of time. And so we need to have the allocation of state resources. Second, some of the Medicaid letters that come out may not be in alignment with where Vermont is at. We might have already done it. So for example, we did Medicaid expansion long time before the Medicaid letter came out that allowed us to do Medicaid expansion, and defaulting back to what the federal government defined as that might have actually carved populations out of that expansion rather than in that expansion. So we look critically at each one of those areas and really assess that. I think one of the things that folks may not know about our current agreement that's different than anybody across the country has gotten is that we have flexibility when another state opens up a new service line. We have more flexibility to adopt that than we've had in the past without going back and fully opening up the negotiations. The second thing that we got on this year is an ability to increase to address some of the inflationary pressures without having to go back and take it out of our cap. So the amount that we're capped, we can take and increase those rates for inflationary to address the inflationary pressures. And you see us doing that this year without actually eating into our cap. And that's something that was also very unique to Vermont. So it's cool. We can increase our rates and the federal government will kick in, whereas in the past we would have had to take it out of more either state dollars or out of the Medicaid cap. Not to get too in the weeds, but I know that's kind of related. I know you are. That's totally there.
So we're going to take Leslie's question, and then we completely went off track, which I apologize, but I think this was a good conversation. Leslie?
Yeah, I'm going to echo it. I think it's a really interesting conversation. And just express a sense of being fearful. I know that you're working with the Green Mountain Care Board on Act 167 and hospital global budgeting. We had, I think it won't be for 2 or 3 years before we even get started on that. I know that you're attributing a lot of costs to travelers, and I'm not sure how that's going to play out, but we'll see.
Yeah, we'll see.
But I don't feel like 100% confident that that's the whole problem of, losing places. So I'm just curious to hear you talk about timeframe and, what are we going to lose as we proceed very slowly trying to move? I get it's an aircraft carrier, we're trying to move it, but what's going to be lost? What's your vision of a timeframe that?
Okay.
Yeah.
It's a great question. So to level set for the room, the Medicare agreement expires in 2 years. We got a 2-year extension. And so in the time frame of CMS, in order to change any ways that they pay, it typically takes 18 months at the fastest and 3 years at the norm. So that sounds really long to all of us. I am one of the least patient people in the world. But what that 2-year extension did was give us an opportunity to do some of this other work to define what we wanted the system to look like differently, and how we would want to pay for it before we go into the next agreement. So the time frame on that is they've been working with us to modify it and hopefully give more flexibility to the state of Vermont. We are the lowest cost Medicare state in the country. If we got the same model as Maryland, who was one of the highest costs and then implemented global budgets, and we went in the same global budget model, we would be in a whole lot of hurt. And so we've been working with them to get to on their model to get more flexibility. They will release their model proposal later this year. They're not negotiating with Vermont 1-to-1, and we will apply probably early next year with implementation of a new payment model and a new model with Medicare in 2 years. I want to say, though, we are not sitting back on our laurels on changes on that. So there's a bunch of different timeframes. I don't think that it is only because of travelers that our hospitals are in trouble. In fact, we've got one hospital system who came to us and said, it's 2 hospitals, and said, can you help us now? Similar to what we did with the Brattleboro retreat, where we went line by line, identified what the needs of the community were, and then identified where they were losing money, and then identified what they should turn on and turn off. And they asked us to do that work with them. Again, that goes to the state, regional, and local level. We are going to start, that work starts now, has been ongoing, but we'll start with the 167 work. We will have a contractor in place who will collect qualitative and quantitative data for the next 6 months. And then we will immediately start working, hopefully, with up to 4 hospitals, including those 2 hospitals who are interested in looking at the regional model, to begin to help give them consulting resources to make some of the changes once they reflect on the data and based on their recommendations. So we're not waiting until the waiver gets negotiated in order to begin to make those changes. For example, we knew that one of the things that we don't have in long-term care, while we do this study of what it is that we need for the demographics, we knew that one of our biggest pain points right now is at least 100 beds for individuals who are complex mental health. They may have behaviors that make it difficult to care for them, maybe bariatric patients, but need more support in a long-term care facility. We're opening that in June. So I don't have one time frame to offer you. What I have is, in the IT world, there's waterfall, which is you come up with a plan and you implement things one by one. We are taking an agile approach, which means we identify the problem and we solve it. We identify another problem and we solve them. And we're doing that over and over again with each of these issues while trying to make sure that we keep a frame across all of the system rather than just on a part. So if one thing impacts another, we're trying to make sure that we work on those both at the same time. So I can give you the 2 years to negotiate the next Medicare model. I can give you 6 months to do the data collection under 167 and then continuous work over the next year with at least 4 hospitals. And I can tell you that we're working on some of those other things on an ongoing basis. For example, the proposals for mental health. Okay, long-winded.
Thank you. And unfortunately, we're out of time. But that was really wonderful.
Thank you.
We appreciate your time. Have a great weekend. And we are going to go off